we know that addiction is not just really addiction. It's addiction with psychiatric issues. Some people do medicate themselves on their own with medications that is not suitable, of course, but that's how they get into this. Actually, a lot of them get into this because they self-medicate, whether even for alcohol and for benzos, but also opiates, and they fight their depression with opiates.
Music bed.
Well, we have the amazing, talented, knowledgeable Dr. Hasan. Dr. Hasan, tell us what your history of licenses are, because I know that you just finished school too, so you've added to that list.
Yeah. So I currently work in my office in Hollister here. So originally I'm a primary care doctor in internal medicine. Started my practice back in 2001. I since then also did emergency medicine too. So I worked at the ER for all these years and still too. During this time, I provided primary care to the local community here. I also, at one point when we had shortages of pain management doctors, severe shortage actually, in Hollister, I started do pain management back in 2008. And then as things progressed, and finally we had issues with addiction. So I started stepping into the addiction medicine too, and I started this about 2012. And so I now have a full kind of practice in both pain management and addiction medicine, which I always think they should go hand in hand, because you cannot do just pain management and not do addiction, because they are intertwined with each other.
Right.
And I did this until 2020, and I decided to add to my kind of recipe. My passion was to do nephrology, so I went to New York and I did 2 years of fellowship in nephrology, and added to that was also a year of critical care medicine. I did this really because I noticed that during my years of practice in Hollister, we didn't have nephrology all these years. We had patients being shipped out, and sometimes even they decided not to go anywhere because there is no dialysis center. Now they have a dialysis center, but at that time was not. And the critical care medicine came in because almost all hospitals are now have closed ICUs, and open ICUs are becoming less and less. And I think it has a value, because doing closed ICU will dedicate a specialist in that area and will make it more able to provide the care without shipping the patients for kind of like common issues. So instead of sending somebody because they have some kind of a chest tube issue and you cannot handle it in a small hospital, for that, that's just a very common issue, and you can handle it if you just have a little bit of background. So I thought it's important to add that too, and that's why I ended up doing this. And so I did total 3 years, and I just came back again in July.
That's amazing. Well, we're glad to have you back.
Thank you.
I've had the pleasure of working with you. Gosh, I mean, we've been open for 9 years, so I would say we've probably been working together close to the 9 years.
Yeah, exactly.
Yeah. And it's interesting to look back, on my journey and dealing with addiction and addicts and the behaviors that come along with it. And, my biggest question, and I feel like this is a really big topic for a lot of families, a lot of professionals, a lot of addicts, is there's treating the addict and taking them off of what's, causing them to steal and sell drugs and all these things, which is, usually opiates, right? And started with oxy, then it went to heroin, then we're seeing the fentanyl. But then there was this gray area of, okay, and I can speak for myself, if I was going to go on a trip with my family, I needed to make sure that if I wasn't going to have enough heroin on me, then I needed to make sure I had at least a few subs in my purse to get me through the weekend, to make sure that I felt well and didn't get sick while I was a few hours away. How has that been for you, treating addicts, knowing that a lot of them were going in to either get drugs and possibly sell them, or use it as a crutch for their opiate addiction and kind of go back and forth, because I could speak for myself as an addiction specialist and having a treatment facility now 9 years into it. Originally, I wanted to save everybody, and I would want to pull my hair out if I couldn't. And I would fight harder for the addict than they would for themselves. And it's gotten to a point where I do my best. We know what we provide. We've saved a lot of lives, and there's a lot of people not ready. And I've come to terms with that, and it took me a long time. So I'm just curious to hear your perspective of being a specialist who is writing that prescription to these addicts who are either trying or manipulating.
Yeah, that's as you know, that's a big question, and it's accumulation of years, not just of my experience, but also the experience of the whole nation. Mm-hmm. It started with something and then progressed to something else, and now we are at this point here. I mean, the whole message was to try to minimize the risk to the patients. Fortunately, some people do make bad decisions. Maybe they are forced into it, maybe they have reasons, but we know that addiction is not just really addiction, it's addiction with psychiatric issues. Mm-hmm. Some people do medicate themselves on their own with medication that is not suitable, of course, but that's how they get into this. Actually, a lot of them get into this because they self-medicate, mm-hmm. whether even for alcohol and for benzos, but also opiates, and they fight their depression with opiates. We know that your opiate elevates your mood, but of course it's not the best. It's not actually in any way a treatment because it just numbs the area of depression, but then it postpones the outcome to a worse situation. So our job is not just provide medication, but you will have to identify. First of all, you have to counsel these patients if you can identify them. Of course, you have. The way you should identify them, either they come in, so they are basically identified already, or you see them in your practice. You see that there is some deviation in practice. The goal here is, or the approach is not to go and punish that patient. Oh, I'm going to take this away from you. No, you have to discuss with him, why is he like this now? Maybe he started with something really legitimate, from pain, and then because of misuse of the medication or not a very well prescribed regimen, he ends up in addiction. Mm-hmm. So you have to counsel and see the best route for that patient, how to have him avoid a worse outcome. We know addiction habits will lead to outcomes, social, financial, and even medical. People overdose, and we see this issue going on every year. And every year we think that we have a solution. It ends up not a solution. They put all these laws to prevent high amount of prescription, but we actually see a shift now. For a while, there was more overdoses on oxycodone and morphine, but now we have the shift into the street drugs, which is even worse because now we have an epidemic of street drugs overdoses. Mm-hmm. So you have to identify these patients, and you also rely on people who kind of a specialist like you, where you are allocated as a person to go to. Mm-hmm. So your job is also to identify them and call me and say, I have this patient, I think we can help him. Same thing, ER. ER is now playing a big role in this. Mm-hmm. Patients show up there with withdrawal symptoms, severe depression, suicidal attempts, and then you have to, as an ER doctor, you have to identify these patients. It's not enough just to treat his, overdose and then send him home. You have to see why he did this. He must have progressed from 2 pills to 4, or for 2 grams, from 0.5 gram of morphine or heroin into 2, and then he overdosed. Mm-hmm. You have to identify these patients and send them to the right people. Which is another issue, which is, we don't want to open that kind of form about insurances. It's mm-hmm. been a battle with them. Mm-hmm. I remember when I started, doing addiction medicine, insurance did not want to pay for it. Did not. They simply did not want to pay for it. Although it's proven by studies that it does help to put these patients on buprenorphine, but still, and it took years. Mm-hmm. Now it is acceptable. Mm-hmm. But it did take years. So it's a maturity process that we all started, and each part of that process is catching up. It's taken long years, but I think we are in a better situation now than I would say 10 years ago, but we still have a lot of things to do.
Right. And what I really appreciate with you, of working with you all these years, is we've seen a shift and we've seen change together. You know, we're seeing different clients coming through our door using different substances. Now, you know, where a heroin addict needed 24 hours to wait to take their first dose of subs, now they're exceeding 72 hours before they could take their first sub without going in a precipitated withdrawal. And now we're finding a window of 72 hours for somebody who's on the streets, highly addicted to these substances mentally and physically. We can't wait 72 hours. And what I appreciate with working with you is like, okay, even since day one, where we used to take clients into your office where you would see them, you always counseled our clients. You always educated them and asked them just to get their mind turning as to why they're sitting in your office. And for that, I appreciate, because I've also worked with numerous doctors where they see within 5 minutes and they're writing a script and they have no knowledge. I'm telling them they probably aren't a good candidate for this. They're begging to differ. And with this fentanyl epidemic that we're seeing now, is we're trying to tweak the protocols a little bit. That's something that's actually going to work for them without having them leave AMA, against medical advice. And so you have been open-minded to doing that. And I appreciate that, because I feel it's important for us to communicate this, because there's a lot of facilities, there's a lot of doctors who are still trying to learn what's going on with this new drug and how we're going to treat it. Because it is, even for us, it's a totally different monster.
Absolutely.
It's different than how we do interventions with these clients than what we did even just 5 years ago. Now, do you ever have, knowing that people are coming in and possibly abusing their medications, do you ever red flag their files?
Yeah, so of course, you know, you have to identify these patients, and there are many ways to do it. You know, there are certain behaviors that carries that, red flag, early prescription, calls on weekends, lost or stolen. You know, these are the old, excuses, but there are other ones too. So patients who are selling part of, so most patients, it's very hard for a patient to come in and say, I'm going to fake this pain to the doctor. Mm-hmm. So almost all of them are a mixture. So with time, they do need some medication, but they sell part of it. Mm-hmm. That's the most likely thing. It's not the other way around. It's not like, I'm just going to this doctor and just going to act something and make a little action here and pretend that I'm in pain and have the doctor. That happens very, very rare. More likely is that the patient does have pain, but because of pressure from family and financial pressure, he will start selling some of his drugs because it does have value. Then these are difficult to find, because they come in on time, because there's no need for them to, they are not addicted to the degree where they need to come in after 2/3 of the month. Mm-hmm. They will wait until their prescription comes in, and they are actually very good patients. When it comes, because they have interest in getting the medication. These are the tough ones to find, but of course, with time, as things evolve, now we have drug screening, which we do by urine testing. We have also the second level of testing, which is actually measuring the level. Because I can take a pill and it will show the urine, and we're like, oh yeah, I'm taking the pill. Mm-hmm. Well, but I'm writing you 3 pills. Are you taking the 3 pills really, or somebody else is using 1 pill and you're using 2? Mm-hmm. So that's where it comes to the next step, which we implemented in our office, a few years ago, where we actually test the level in the urine. Because there is some kind of comparison. It's not 100% bulletproof, scenario, but it does tell you that if there is only small amount, and I'm giving you 4 pills, there is a problem here. Mm-hmm. And that's how we gauge things. And it is hard to find, and it's to identify these patients. It's not an easy job, because as I said, they are legit. They have reason. They have multiple surgeries. That one surgery failed. There was complication surgery, and now. So they have legitimate requirements. It is hard to tell. Is it 100% requirement, or this is just a mixture of things? So these are tough to find, and you have to have experience, and you have to have the tools to find them. You cannot do it on your own. It's very difficult without doing the drug testing and the levels. It's almost impossible to find them.
Right. Do you feel if somebody comes in and is honest, I'm a recovering, or I'm trying to get off of opiates and I want to be on maintenance, I've been to 15, 20 programs, do you find that somebody being on long-term MAT is beneficial if they're able to then maintain a job, they haven't relapsed on heroin or fentanyl, that they are what makes a candidate for long-term MAT in your professional opinion?
Yeah, thank you so much. That's a very important question. When you approach a patient that comes to you, he wants help. He doesn't want to spend his day and night buying drugs. He wants to focus on his life. But there's no much space in his time to go into rehab for 3 months. What are you going to do? You're going to tell him, sorry, I can't do this? You have to work with this guy. So that's why the methadone clinics were kind of created, although the idea of the methadone clinic was originally to avoid HIV but still they went into maintenance programs, and a lot of it is actually to put them back again into life. The Suboxone is better, or the buprenorphine is better, because methadone is still a medicine that can give you a low energy, and it does not let you do physical work. It can get you cannot really do truck driving with methadone. It's impossible.
Right.
So, but with buprenorphine, yes, you can. You can go back again to your life, and if you understand what's the patient's situation, I mean, he's been on drugs for 10 years. What are you going to do now? Tell him to stop his life and have his family go somewhere else until he gets 6 months of rehab. It takes 6 months to rehab. It's very difficult. So all we can do with him is okay, listen, I understand, but you have to agree with me that we are going to do this program and we're staying with it. You're not going to go back again. We're going to stay with this, and if you have to stay on it for 5 years, that's fine. And whenever you are able to take that 6 months rehab, tell me, and we will, send that patient to you, and then we can work on it.
Right.
But somehow you have to understand the patient's perspective and his life, because as you said, a lot of them are functioning, addicts. They go to work and they actually perform well, but they have a very dark side of their life that they hide, and they are miserable with it.
Right. That was me.
Yeah.
I showed up to work. I was still there. My mom was just like, I don't know if I can't tell. She looks okay. I can't tell if she's on drugs or not. But I had this flip side of my life, and it was just it was getting exhausting though. And I'm really thankful that I was able to go to a program who didn't believe in MAT. But I'm a very small percentage of opiate addicts who are able to go to a program once and once only and not take any sort of long-term medication. So but then I have, a sibling who needed numerous programs and probably is a good candidate for MAT. So it just depends, and I see it for many different clients. Do you ever feel like some people come in and shouldn't be on it and get put on it too soon without seeing alternative solutions through treatment?
Yeah, I mean, I see all kind of patients. In outpatient, usually a patient who walks to the office, they are the kind of people who have life and have families, and they want to maintain it. But in the ER, no, I see the extremes.
Yeah.
I see the ones who are in trouble with the law, who are under some kind of surveillance by the police, and they have really hard time finding a job, but still they want to change.
Right.
Now, the treatment for the first one is not the same as the second one.
Right.
The other one really you cannot just have that patient come to your office and fix this problem. It's not going to happen. That's not a person. That's a person who I have to send it to you. He has to have help from his family. You have to call his family and tell them, listen, we need to help him. So, accept the fact that he's not going to work for the next, month or so until he rehab from your facility. And then we can discuss him coming to the office and make him put him maintenance. Not all of them need maintenance, as he said. Some of them, if they are short term, if you have done drugs for a year or two, you can get out of it within a month. But if you have done it for 10 years, high dose, these are tough ones to, because you can stop the physical withdrawal, but they will end up with depression. And it takes a long time for that depression to go away, and until they assimilate back in life and find their, you have to really create another environment for them.
Right.
And that's why there are different versions of patients, and each one fits into a certain category. But that's why we have to have, comprehensive system, which for a long time we didn't. I remember there are days where I was working in a hospital as a hospitalist in our Hazel Hawkins, a patient who is addicted to narcotics. That's it. We give him the treatment. He comes in like with, let's say, infection because we get him, and you're discharging him. We discharge him to where? You discharge him back again to where he came from, the same risk factors that you. So it was not a very good plan in the past.
Right.
Nowadays it's better. Now, we can call you and say that we have a patient like this, and he is interested. So at least there is a chance for these patients to, they come in with sepsis and infection in their skin from injection, but they don't have to go back again to the same, dark environment they were before.
Right.
Now we can create another avenue and have him recover and give him at least a hope.
Right. Do you feel that addiction is getting worse, or is it the same as when you first started in your career? What are you seeing shift a bit with this?
Yeah, so addiction is not just a social problem. It is actually a medical problem, because most people don't like to go to doctors to treat themselves, even if they know they're depressed. They don't want to go to the psychiatrist. So what do? They start drinking alcohol. Somebody gives them tramadol. Oh, I feel better. That medication helps me. Yeah, let me just do more. So addiction is kind of like intertwined with psychiatric issues. And psychiatric issues are embedded in our society. I mean, you can't have a society without having psychiatric. There's 5% of people who are severely depressed. There's 5% of people who have bipolar. There's 5% of people who are schizophrenic. There's, I don't know percentage, but there's schizoaffective disorder. There is a lot of people who have dysthymia. How can you treat this? How can you, unless if you have a very strong, comprehensive psychiatric or mental health, which we don't have at all. Actually, our mental health situation is terrible. We don't treat them. We don't screen for them. Although Medicare does, but that's only for a portion of patients. But we don't screen like teenagers. We don't screen.
That was going to be my next question. Do you feel before any symptoms are showing that we should be introducing our youth and screening them and trying to teach them tools of how to deal with, maybe we wouldn't use the word anxiety or depression for an 8-year-old, but when they're feeling really, really sad or really, really nervous, starting to, work with them at that age?
That will be the optimal way of managing your communities and your society, is to screen for, if you want to treat addiction, you have to treat mental health. You have to establish mental health, because a lot of these people, they don't choose to go to become a drug addict because they like it. Some do recreation, but these are actually the fortunate ones with the money, and so most people medicate themselves. This is what happened with teenagers, what happened with young people. They go into life and they found, I'm depressed, but this hydrocodone medication really helps me. Somebody gave it to, I'm going to take it every day. And he started a journey of addiction. Of course, there is why is this? Because this is attached to financial gain to somebody else. So unless I can't see how we as individuals can do it. We can preach. We can, how should I say, call for that help. But we really have to have a budget for this. And this is not going to happen from our pockets. This is going to happen from the government. The society has to address the issue of mental health. If you agree to live in a society that has roads and medical services and water and electricity, you have to accept also there is 5% of your population who have mental illness. You cannot just exclude them out and say, I'm going to take the 95% and the other 5% I'll put them in jail. That's just very selfish.
Right. I agree.
Very selfish look at society. If you agree to live in this society, then you have to accept the good and bad.
Mm-hmm.
You can't have 5 kids. One of them is bad. How am I going to throw away my kid? No.
Right.
Yeah. You have 4 good kids, but you have 1 bad kid. No, you have somebody, his IQ is not good.
Right.
What are you going to throw him away? You have to manage him.
Mm-hmm.
Same thing with the society. So we have to educate the society, and they are still far away from this.
Yeah, and I agree. I mean, and that's what we're doing is we're starting here. I am, this is the most that I can do is spread the message and bring professionals such as yourself on here, and I am with you, and I agree. And there's more that needs to be done, and all we can do is try to chip away at it as best we can and educate the ones that we're able to touch, and hope that it spreads more.
Now we have this podcast. You should use it, to really educate the whole society.
Yeah, I agree.
We should target everybody, not just the sick people, but
Agreed.
also the healthy ones, to go and help the sick people where they are landing. They are working in, let's say with the government. Go and ask for help for these people. Don't just stay quiet about it.
I agree. Well, then they're complaining about this happening and break-ins and this and that. If we started, I think we just need to start with our youth. That's the best that we could try and do, is educate them younger before they experience things. And if us as adults are not educating these kids, and they're learning from a friend and they're learning from an acquaintance at school, I mean, this is just how it keeps spiraling too.
Yeah, absolutely.
Yeah, a lot to be done. Well, Dr. Hasan, thank you so much for taking the time to come here. It's always, I love picking your brain and learning more. And
you're like a great asset to the community. We need people like you, because as a doctor you can't have, you're not an educator. You can, but you're kind of like imprisoned in your office and your legal and medical issues. But you are an outspoken person. We rely on a person like you to educate the society, and even create some kind of policies or push for it. This is how it starts. It starts like this. It doesn't start, somebody just, think about it overnight and bring a policy. It starts with people like you pushing toward, repair in the society.
Yeah.
But thank you so much for your help.
I appreciate you so much. Thank you so much.